It's a pleasure and honor to be here today and discuss one of my favorite topics. With regard to this presentation, the only potential relevant natural relationship is with a company called Nihon Mediphysics. It's a company in Japan that's developing new ways to image the adrenal glands, but nothing's been done in humans yet. So that won't be touched on today at all. I do need to disclose my ABIM service. ABIM is American Board of Internal Medicine. This is the organization that certifies our endocrine fellows when they finish training and recertifies us every 10 years. I chair the Endocrine Specialty Board. I'm a member of the exam committee. I'm a member of the ABIM Council. As is true for any ABIM candidate who's taken the certification exam, I've signed a pledge of honesty, which I've agreed to keep the ABIM exam confidential, and no exam questions will be disclosed in my presentation. So I'm required to read this slide every time I give a talk. It's an interesting time to be at ABIM. In the old days, when you got that level, it's like the pinnacle of your career. It's changed a little bit. Now it's more like you're the target. And I have to say I'm working really hard at this and trying to effect change at ABIM so that it makes certification and recertification a reasonable experience for all of us. Okay, so what's a computer-based CPC? This is going to be an interactive format. You guys are going to help me work up these two cases. I'll present you with a case. We'll go on to a test menu, and then you pick what tests you want. The person that speaks up the loudest is the one that's going to give the test they want. Once you've come to the conclusion of the diagnosis, you can move on to the treatment menu. We have 2 CPC cases, about 20 minutes per case. After each of the cases, we'll review some email-based concepts. So the first patient is a 52-year-old woman. She's been hypertensive for 2 years. It's accelerated the last 6 months. Episodes of forceful heartbeat, sweats, occurring every other day, 15 minutes duration. Current treatment, ACE inhibitor, thiazide diuretic, and beta blocker. Physical exam, blood pressure, not well controlled, 158/98, heart rate 70, BMI is 23.1. Sodium, potassium are normal, creatinine is normal, fasting glucose is normal. So when you think about hypertension and spells, here's a list of tests that you could consider. There are other tests you could do too that I haven't put on this slide. So if you pick clinical assessment, that would just go to a slide that gives you a little bit more information, and you might want to ask questions about the patient at that point also. So where would you like to start? I heard plasma metanephrines. And then I heard clinical assessment. We'll do both of them. Plasma metanephrines. Metanephrine is normal. Normetanephrine is elevated at 4.1, upper normal 0.9. And you want a clinical assessment. There's no family history of pheochromocytoma or paraganglioma. Any other questions that you want to ask this patient?
Weight stable or?
What was that?
Weight stable or weight loss?
Weight loss? No weight loss. Medications, the only meds are the ones I listed, which were those 3 antihypertensive agents. Menopause. She has gone through menopause? Yes. So alcohol. She does not use excess alcohol. Okay. What now?
24-hour urine.
I heard 24-hour urine. Metanephrine is normal, but normetanephrine is elevated. Upper normal is 900 micrograms. She's 1,870. Norepi are normal. Dopamine, however, is elevated. 1854. Upper normal is 400. What was that? CT, MRI, actin pelvis. She has a 3.5 by 2.4 centimeter right adrenal mass. Before contrast administration, with radio densities 5 Hounsfield units. There's 76% contrast washout at 10 minutes. Ready for treatment menu, or do you want to do more tests? MIBG? She has a high SUV lobulated left upper mediastinal mass. There are no other abnormalities. The adrenal nodule does not light up. Chest imaging, okay. You're doing good. So there's a 4.5 by 7.5 centimeter lobulated left upper mediastinal mass. Treatment? Genetic testing? We did genetic testing. I did the succinate dehydrogenase panel. She has an STHC mutation that's pathologic. Now treatment. Okay, good job. So your options, you could take out that right adrenal nodule. You could do thoracic surgery or no surgery, treat with chronic adrenergic blockade. Okay. So she was prepped with phenoxybenzamine and Demzer's alpha-methylparatyrosine. We use that because she had a predominance of dopamine, and this will cut her dopamine secretion in half. And we don't have a good way to block dopamine. This is just an intraoperative photo with a lung collapse. You can see her ribs here. This is the tumor mass here. This is the top of the pericardium here. This is just a note from the surgeon. He noted that the tumor involved the left phrenic nerve, which passed through the middle of the tumor, unfortunately. Similarly, identified the vagus nerve, which passed right through the middle of the tumor. So both of those nerves had to be sacrificed as part of this operation. This is what the tumor bed looked like once the tumor was resected. See the arch of the aorta and the great vessels. So tumor specimen, once it was taken out, 11 by 8.6 by 3.8 centimeters. Follow-up, 1 year post-op, normal Mets and CATs, negative chest CT. So that's her pre-op chest CT, and this is what it looked like a year later. Remember, we had to sacrifice the phrenic nerve and vagus nerve. You can see the paralysis of her left hemidiaphragm here. So the key points with this case, Theo has a unique imaging phenotype. Never mistake a benign adrenal adenoma for a pheochromocytoma. The imaging phenotype of Theo, dense, vascular, areas that are inhomogeneous or cystic. Before administering contrast, radio density is typically more than 20 Hz per unit, and it has slow contrast washout. So here are some typical adrenal pheochromocytomas. Dense, vascular, cystic nature to them. It's just a coronal image there. Whereas the benign cortical adenoma is hypodense when you compare it to the liver. It's homogeneous. Hz per unit score before giving X-ray dye is less than 10 and has fast contrast washout. So here are some typical benign cortical adenomas. And if you understand imaging phenotype, you understand that those patients can't have Pheo. And the case you worked up with that adrenal mass, when you look at that and you see the downstream score is 5, you should know can't be Pheo. And you guys appropriately suspected that, so that was great. Catecholamic screen tumors can be found anywhere in the midline of the body, anywhere from the ears to the scrotum. Questions on pheochromocytoma or this case? Yes?
Didn't use beta blockers to prep her?
The question is, did we use beta blockers to prep her? She was already on metoprolol, so I kept her on it. That does bring up a point. I get this as an email question. You know, the patient's on a beta blocker, should you stop it and then start your alpha blocker? No. They've survived the beta blocker already, right? So you keep them on the beta blocker and you add the alpha blocker to it. Other questions? Well, let's do a couple of email consults here. So this is my Outlook inbox. This is my folder on email consults. And these are the number of email consults I've had over the years, 5,914. So if we search this inbox for pheochromocytoma, we get a total of 1,743. So we're going to look at some of those email-based questions. Bill, hope all's well. We wonder how you currently investigate pheochromocytoma and paraganglioma from a genetic perspective in your clinic. Do you follow the algorithm, Figure 1, the JCM publication 2014, presented in the Endocrine Society Guidelines? So this is the algorithm that's mentioned in the email. And you can see if you start at the top here, you start with a diagnosis of pheo or paraganglioma. There's a syndromic presentation and targeted genetic testing. So for example, if the patient had a retinal angioma, you think of von Hippel-Lindau syndrome. If the patient had a goiter and was due to medullary carcinoma, you think NEM2. Metastatic disease, this algorithm suggests check SDHB first. If that's negative, SDHD, SDHC, VHL, or MAX. Benign disease, based on location, if it's skull base neck, SDHD, B, and C. If it's extraadrenal, but not in the skull base and neck, and depending on the biochemical phenotype, if it's dopaminergic, like the patient I presented today, check B, D, and C. If it's noradinergic, B, D, C, VHL, MAX. And if it's in the adrenal, then based on the biochemical phenotype, these different mutations. So how did I answer this email? Oh, this algorithm's in the Endocrine Society Guidelines that were published JCM in 2014. That algorithm generated a lot of debate on the writing committee, argued that by the time it got published, everyone would be doing next generation sequencing to make the algorithm obsolete. It is obsolete. If the patient has a paraganglioma, I do the SDH panel. If that's negative, next gen sequencing. For pheos, adrenal pheos, less than age 40, next gen sequencing. With next gen sequencing, it's cheap, you get all the genes at one time. Whereas if it's a paraganglioma like the patient I presented, it does make sense since the highest probability is going to be an SDH mutation to do that testing. Here's another question. I have a middle-aged woman on an MAO inhibitor, long-standing, can't go off without becoming suicidal, who has questionable pheo symptoms, but she was on Dr. Google and had someone test her catecholamines, and they're a bit high. Then she got a CT showing 1 centimeter left adrenal mass, negative on MIBG. Because of her insisting, we ended up doing selective venous sampling. And there was no gradient between the catecholamines stream right and left. Well, that was confusing. She had your name and previously tried to make an appointment with you. Thoughts on additional workup? Don't have enough for me to take out her left adrenal. So my answer was, the diagnosis of adrenal pheo in a patient with an adrenal mass should all be about imaging phenotype, not about symptoms, not about biochemistry. Thus, if this 1 centimeter left adrenal mass is a hypodense nodule on CT, you are done. It cannot be pheo. Biochemistry is meaningless in patients treated with MAO inhibitors. Finally, it's very rare for a 1 centimeter pheo to have a factory big enough to make enough catechols that would cause symptoms. So I think it's extremely unlikely that this patient has a pheochromocytoma. Here's another question. I have a male patient who was diagnosed with MEM2A at age 42. He's now 65. My patient had hypertension at the time, was told that at CT was found to have bilateral adrenal lesions that were resected. He had a thyroidectomy for medullary thyroid cancer, but he did not apparently have parathyroid disease. No genetic testing was performed for my patient or his brother. Neither have children, neither want testing. Father died during surgery at age 39. Autopsy found him a pheo. I've checked his urine for pheo recurrence, and he has consistently elevated but stable values and easily controlled hypertension. He's had a negative PET CT 2004, 2008, negative triatite scan in 2005, negative MRI of the neck, abdomen, 2009. This email's from June of 2015. He's not wanted further imaging. His last 2 urines are shown below. So here are the urines. So in 2009, urine metanephrine, or appropriate upper limit of reference range would be 400 micrograms. Upper limit for norepinephrine is, metanephrine is 900 micrograms. All of the false positives are with normetanephrine and norepinephrine. You don't get false positive epinephrine or metanephrine, unless your patient's in the ICU and experiencing stress. So what's interesting about these urines, so then in 2012, the metanephrine is 546, and it's higher in 2015. So even though these don't look like big numbers, that's diagnostic. Absolutely, this guy's got recurrent pheo. So his question is, what do I do now? I know CT is the preferred imaging for presumed metastatic pheo and MRI for paraganglioma, but the stable values on revealing imaging to date do I keep looking or just follow urine image if values increase? With that level of urine metanephrine, the residual disease should be easily visible in one or both of the adrenal beds. He never told us if this patient had complete bioadrenalectomy or cortical-sparing adrenalectomy. I suspect that's what happened. It is very rare for MEN2 to have malignant pheo, assuming there was no tumor spill at the time of surgery. So if you violate the capsule intraoperatively of a cystic pheo, you spill it in the retroperitoneum, you've taken a benign adrenal pheo and you've created a malignant, incurable situation. So yes, I would definitely do a CT with contrast. Hope this helps. Sometimes, when I get this advice, the person that asked the question gets back to me and tells me what's happening. Most of the time they don't. In this case, I wrote him, did you do the CT? If yes, what did you find? I did indeed. Found a 2-centimeter mass in the right adrenal fossa waiting on surgery. Hope it hasn't been there long. Well, it's been there just as long as that metanephrine was rising. Feel bad that I didn't get it sooner. There's really nothing lost. I mean, it's only a 2-centimeter epinephrine producing pheo. So before we move on to the aldosterone case, any questions about pheo? Yes.
So what about with the MAOIs or the tricyclic antidepressants? How high would you expect the
Right.
epinephrine to be? Is there a limit?
So the question is, with drugs, how high can the norepinephrine, normetanephrine be? And again, all the false positives with drugs or any other situation are norepinephrine, normetanephrine. So you can get 5-fold elevation in norepinephrine, normetanephrine. We're talking about big numbers, big numbers. Even higher numbers if the patient's on a substrate for catechol-synthesis, which is levodopa. So patients taking Sinemet for Parkinson's disease, for example, their dopamine levels would be more than 10-fold elevated, norepi, normetanephrine more than 5-fold elevated. Other questions?
Do you stop the antidepressant when you run the test?
So the question is, do you stop antidepressants when you run these tests? Well, you have to make a decision. Now, that case that he mentioned, the patient was suicidal. I wouldn't stop the MAO inhibitor, right? And again, I think the answer there was easy. They already did a scan, and they have a nodule. It's 1 centimeter. I bet it's a hypodense cortical adenoma. So if it's a patient that's on a TCA to help with sleep, for example, sure, stop it. Wait at least 3 weeks, though. You don't stop it for 3 days. At least 3 weeks, and then you do your 24-hour urine. Or you can test while they're on it. If their numbers are normal on a TCA, you're done. Yeah, that's great. So those are your options. If it's a patient like, let's say it's a patient on an MAO inhibitor, or let's say an antipsychotic, the lab values are 3-fold elevated, you can't stop the drug because of concern about the patient's welfare, there's a simple test to do. That's called a CT with contrast abdomen pelvis. 85% of these tumors are in the adrenals. 95% are somewhere between the diaphragm and the pubis. So a CT with contrast is excellent. These are not small tumors if it's causing symptoms. Average size is 4.5 centimeters. They're not hard to find. So there's a question, what about beta blocker? So in terms of stopping that to do your testing, well, here's the good news for us. Antihypertensive meds, beta blockers, alpha blockers, calcium channel blockers, diuretics, ARBs, ACE inhibitor, it doesn't matter. Antihypertensive meds do not interfere with this evaluation. What interferes? Tricyclic antidepressants, number one. Cyclobenzaprine, which is popular these days for fibromyalgia. What's its trade name? Flexeril? Yeah. So that's a tricyclic. So that causes very abnormal values. I mentioned the Sinemet, antipsychotics, MAO inhibitors, but that list does not include antihypertensive drugs. So never stop an antihypertensive drug to test for fever. Let's go on to primary elder, or suspected primary elder. It's a 64-year-old man, hypertensive for 15 years, controlled with a beta blocker until 6 months ago, when hypertension accelerated. Now suboptimal blood pressure control on a calcium channel blocker, ACE inhibitor, thiazide diuretic, and a beta blocker. So 1, 2, 3, 4 antihypertensive drugs. Hypokalemia was found 2 months ago. He's currently taking low-dose replacement, 10 melatonin once a day. Physical exam BMI is 43.7, blood pressure 138/88. His initial labs on his current meds, sodium's normal, potassium's normal, creatinine's normal. So here's your hypertension hypokalemia test menu. That same clinical assessment tab. You get a plasma aldosterone concentration, plasma activity ratio. You can do a confirmatory test for primary aldosteronism. You can talk to the patient. You can ask them, do they want to pursue the surgical option for the treatment of PA? You can do adrenal CT, adrenal MRI, iota cholesterol scintigraphy, overnight DEX suppression test, posture stimulation test, 18-hydroxycorticosterone level, adrenal vein sampling, test for glucocorticoid remediable aldosteronism, and when you're ready, we'll go on to a treatment menu. So where would you like to start here? Back ratio. So this is just a screenshot from the Mayo Clinic electronic medical record. So I saw this patient September 2014, so he's got a normal potassium. Aldosterone of 16, reading less than 0.6. And to be honest, I don't look at a ratio. The reference range for ratio is impacted in a major way by the denominator. So for example, you can have an aldosterone level of 3, and if your renin assay goes down to 0.1, divide 3 by 0.1, and you have a big number, 30. Most of us use an aldosterone ratio cutoff of somewhere between 20 and 30. But if a patient has a plasma aldo of 3, that's not primary aldo. So I've made a case every time I give a talk that we should use a cutoff for aldo. We use a cutoff of 15. That's based on patients who've been cured with surgery of primary aldosteronism. That means there'll be people with PA who have aldo levels less than 15, but they probably have bilateral hyperplasia. So we use 15, you could use 10, you could use 12, just use some number. And don't rely on the ratio. I think endocrinologists are better than that. This ratio was developed for primary care providers. It's a simple tool. So we should look at the renin, you want to see it less than 1. The aldo, you want to see it higher than 15. If it's 14, sure, that could be PA. But the lower the aldo, the less likely it's going to be a surgically curable form of PA. So now wait a minute. This guy's on an ACE inhibitor, calcium channel blocker, a thiazide diuretic, a beta blocker, and I tested for primary aldo on all those drugs? Yeah, you bet. So I don't have PA. If I took 20 of lisinopril 4 hours ago, my renin would be up here, my aldo would be down here. If you have a patient with PA, it's hard to make their renin budge. they're on ACE inhibitor, their renin stays low, their aldo stays high. It's a stress test. So when you see a low reading in a patient on ACE inhibitor, that's powerful information. Never stop any drug to test for PA. Just test. It's a barrier. It's a barrier that endocrinologists, to be honest, have put up. There's this thought out there, everyone has to be on an alpha-1 antagonist and verapamil. That's nonsense. I mean, if you're doing a study, sure, but we're taking care of patients. So in my patients, most of them are like this guy. He's poor control of 4 drugs. Who's ethically going to take him off those powerful drugs and put him on a weak alpha-1 antagonist and a weak CCB? So just go ahead and test. Now let's say reading comes back to your patient's on a diuretic and ACE inhibitor. Yeah, maybe the diuretic ACE inhibitor caused it to be 2. Taper it, stop it, substitute other drugs, recheck 2 weeks later. But most patients are like this. So I never stop blood pressure meds to do the L-to-reading ratio. Nothing causes false positive testing. That's the important point. If you use a cutoff for aldosterone. Nothing causes false positive testing. False negative, yes. If they're on a loop diuretic, ACE inhibitor, ARB, you might get that reading of 2. In which case you taper those drugs, stop them, wait 2 weeks, or retest. Okay, so aldo's inappropriate for the renin. What now? I heard confirmatory test. So there's many ways to do this. You can do the 2-liter saline infusion over 4 hours. Typically, we put our patients on a high sodium diet for 3 to 4 days. We then measure urine, 24-hour urine for sodium. You want to see it greater than 200 milliequivalents. If it's greater than 200 milliequivalents, the patient's volume expanded. Renin will be low, aldosterone will be low. Whereas if aldo is greater than 12 micrograms, that's a positive confirmatory test. So he did a good job on his high sodium diet. Urinary sodium is 292. There's no reason to make renin, no reason to make aldo. His aldo is very inappropriate at 16. So that's a positive confirmatory test. What now? CT? I heard adrenal vein sampling, adrenal CT. So I heard we should talk to the patient. Okay, we can do that. So we talked about medical treatment options. There's basically 2: spironolactone and eplerenone. He's keen for a surgical resolution. He understands that if he has unilateral adrenal disease, that surgical resection will cure the aldosterone excess and improve his hypertension back to his monotherapy days. You can't tell these people you're going to make them normotensive when they've had a long-standing hypertension. You're going to cure the part of their hypertension that's due to PA, but this, the genetic part, no surgery is going to fix. So, yep, he would like to pursue. Then I heard adrenal vein sampling and adrenal CT. Let's just take a vote in the room. How many want CT? How old is he? He's 50?
64.
54. How many want adrenal vein sampling next? Okay. So we'll do CT. So these are axial cuts, and I'll just walk you through them. So we're starting high. So you can see the right lung here and left lung there. First adrenal you're going to see is on the right. And when you first see it, there's actually a nodule there. You can see part of the normal limb up there, but it's a sizable adrenal nodule. Start to see the top of the left adrenal here. So here's the left adrenal, looking pretty normal. This nodule is still persistent on the right. We're just marching down toward the legs. Here you can see, here's the top part of the adrenal, and you can see this nodule just coming off the tip of that limb. Maybe a little thickening in the left adrenal. See that right there, it's thick. The adrenal shouldn't be any thicker than diaphragm, which is this here. The nodule's disappearing on the right. There's normal component of the right adrenal, still thick on the left. We'll march all the way down. You still see the left adrenal here. and it's gonna disappear. Here are the coronal cuts. So here's that nodule on the right adrenal. Here's the left adrenal. So he has a 3.7 centimeter mass, radio density is 12 Hounsfield units on the right, and he has some mild thickening on the left. Now what? So how many want to go to treatment menu for surgery? How many want to do adrenal vein sampling? Majority want adrenal vein sampling. It was done. So this is the catheter coming up the IVC, looping over. This is a hepatic vein here. This tip is hovering over the orifice of the right adrenal vein. This is a guide wire extending into the right adrenal vein. You can say, why don't you just put the catheter down there? If you do that, you actually block inflow from tributaries in the right adrenal vein, and you can bypass the aldosterone-producing adenoma. So you want to be right at the orifice. We actually wrote a little paper about this using a guide wire to facilitate preventing overshooting through the right into the adrenal gland, and let it hover over the orifice. On the other side, so here's the catheter, comes up the IVC. This is the left renal vein. This is interphrenic vein. This is adrenal vein. We typically stop the catheter down here. So it's going to be a diluted blood sample because of interphrenic vein inflow. That's not a problem. I'll show you how we deal with that. And I actually view it as a good thing because usually the cortisol is going to be lower on the left, and that shows you that there wasn't a blood tube switch in the lab. Okay. It's just another screenshot. I saw the patient on September 25th. We did pyramid sampling on the 26th. You can see the labeling is really clear. You can see the cortisol levels are much higher on the right and left than they are in the background IVC, so it's successful sampling. And then we'll look at the aldo levels in some more detail. Now I'm showing you this, there's a standard report. Any place that's going to do AVS, you need to have this. I saw a patient this week. He's had AVS 3 times already at other centers. And I'm looking at the data, I can't tell which blood sample goes to which body part. I mean, how can you make any sense of it? All 3 times they did not get in the right adrenal vein, apparently. So we wrote a paper back in 2009 on this, and the keys to successful adrenal vein sampling are actually pretty simple. And we came up with 5 keys, but one of them is just this point I'm making right now. You need to have an adrenal vein sampling specific report so everyone knows where every lab value is coming from. So we'll just make these numbers much bigger so that everyone can see it. So here are the cortisol values. You want the adrenal vein cortisol values to be at least 5-fold higher than the IVC, than background. And you see that's true. You see the cortisol on the left is lower, that's because of interphrenic vein inflow. So this looks perfect. So successful sampling. You have to have successful sampling to interpret the next step. And here are the aldo values. So the aldo on the right is 705, and on the left about 3,000, IVC 38. To correct for this dilution between the right and left, divide the aldosterone by the cortisol for the AC ratio. So 705 divided by 783 is 0.9. 2,980 divided by 283 is 10.5. Then you compare those 2 numbers, divide 10.5 by the lower value. So the aldosterone lateralization ratio that's corrected for cortisol is 11.7 to 1. Anything more than 4 to 1 is consistent with unilateral disease. Also, it's nice to see that the AC ratio in the non-dominant adrenal is lower than background, lower than the IVC. That's telling you that this adrenal is a pretty wimpy contributor to the circulating aldosterone. That's always a good thing to see. But our primary metric is this should be at least 4 or higher for the dominant adrenal. So it turns out that nice big nodule on the right, it's not making aldosterone. It's making aldo as little aldosterone-Prussian adenoma in that thickened adrenal. Aldosterone-Prussian adenomas can be 4 millimeters, 3 millimeters, cause the whole syndrome. They can be visible on CT. So these are data we published back in 2004. This is the aldosterone lateralization ratio on the y-axis, so that's the cortisol corrected aldosterone lateralization ratio. Here's the cutoff of 4:1. These are patients with aldosterone-Prussian adenomas. The circles are filled for those that went to surgery and were cured. Circles are open when we put the data together if they hadn't gone to surgery yet. So you can see that basically anyone that had a lateralization ratio over 4:1 was cured. Now there are some that are less than 4:1 and they were cured. This is not a perfect test. When you see a paper and sensitivity specificity is 100%, there's a problem, right? That's not human beings they're testing. I can't tell you why these numbers are down here, but they are. And these patients were cured. So we knew a cutoff over 4:1 will cure the patient with surgery. Less than 4:1, we know there's some adenomas hiding in there. Now these patients have bilateral hyperplasia. We sent these 2 patients to surgery because they were between 3:1 and 4:1. They were made better, but we didn't cure them. They still had autonomous aldosterone secretion, as did these 2 patients down there. So the patient I'm presenting here would fall right there on the graph. So it's pretty clear that he should be cured with an operation. What else would you like to do? So the question was, what do you do with the right adrenal nodule? Well, that's for you guys to answer. You're working this case on. Okay. Dr. El-Zerani says he'd do an overnight dexamethasone suppression test. Let's see if I did. I did. So the 1 milligram overnight dex suppression is normal. So this right adrenal nodule is not autonomously producing cortisol. That's important to know because we're planning to take out this left adrenal. And if he had subclinical Cushing's on the right, that's kind of problematic, but he doesn't. The comment is you have to exclude pheochromocytoma. I'd make the argument that although the Pounce is score, I think, was at 12, you know, it's pretty doggone close to 10, and that, to me, doesn't look like a pheo. Depending on your surgeon, they may require you to have normal metadephrines in the chart before your patient with PA goes to surgery. I endocrine surgeons trust me enough that I didn't do it. Okay, so let's go to the treatment menu. Options: treat with the MR antagonist, right adrenalectomy, left adrenalectomy, bilateral adrenalectomy. Okay. So he had a 6 millimeter cortical adenoma that was probably in that thickened area we saw. We always measure the aldosterone the day after surgery. We've done the right thing. It should be undetectable. This was less than 4. We always stop the potassium supplement, stop drugs that could raise K, like ACE inhibitors, and then we cut other drug doses in half. So that's kind of automatic post-op. And we continue to hydrochlorothiazide. The risk post-op happens about 1 out of 20 patients is they become hyperkalemic in a clinically important way. So we check their serum potassium once a week for 4 weeks. We did that in him, and his potassium remained less than 5.2. For that 1 patient out of 20 where they become hyperkalemic, they have temporary aldosterone insufficiency. It can be because the kidneys aren't making renin, or it can be because the contralateral adrenal hasn't made aldo in a long time. You just give them fludroclozone, Florinef, 1.1 milligram tablet, once a day for 2 weeks. And by then, the kidney's making renin and the adrenal's making aldosterone. 18 months post-op, hypokalemia is resolved, blood pressure is good, and he's on 1 agent. He's on a low-dose beta-blocker. So it's a huge success story. So when you see these studies that say their hypertension cure rate is 100%, again, that's impossible. Our hypertension cure rate at Mayo Clinic is about 30–35%. That's because a lot of these patients have essential hypertension, or they have long-standing hypertension and probably have some irreversible peripheral vascular disease.
Could it be due to overdiagnosis? I mean, for those that we don't cure, maybe we made mistakes in diagnosis.
So the comments made, if the hypertension cure rate is only 30 to 35%, could it be wrong diagnoses? They didn't have PA to begin with. I can tell you at our center, what I just quoted you, we published in Annals of Internal Medicine, PA was cured in all of them. They had PA, it was cured. Yeah. Yeah. Way in the back.
What if your patient was too old to tolerate surgery or didn't want surgery? What was the course of that?
Yeah, so the question is, what if the patient was too old for surgery or had a lot of comorbidities making surgery risky or simply didn't want surgery? There's nothing wrong with an MR antagonist. Spironolactone or Clarinel. As you all know, spironolactone has a significant side effect profile. It's not only an antagonist at the MR, it's antagonist at the androgen receptor, and it's an agonist at the progesterone receptor. So in premenopausal women, it causes irregular menses, and in men, doses 50 milligrams or higher can cause breast tenderness and gynecomastia and sexual dysfunction. Clarinone is shorter acting, doesn't have that side effect profile. It's more selective for the MR, but it's about a third as potent, so the dose has to be 3 times higher. It's short acting, so it has to be a BID dose. So if he said, I don't want to pursue the surgical option, right, we would have that discussion about those 2 agents, see which one the patient would want to start, and we would initiate it up front.
Why would you not do an example? When would you just do a CAT scan and go surgery? I thought the reason was recently surgery.
Right, so the question is, would you not do adrenal vein sampling? So if you read the 2008 Endocrine Society guidelines on primary aldosteronism, there was only one pathway, and that was from CT to surgery. Everyone had to have adrenal vein sampling. I argued against it. I was on that task force at the time, but I was outvoted 6-1. We rewrote the guidelines. They were published yesterday or the day before. I'm very happy to say now there's a dashed line around adrenal vein sampling. And it's for young patients, 35 or younger, unilateral macroadenoma, and fierce PA, or spontaneous hypokalemia, plasma algo over 30. So patients with adenomas have more severe disease. So if they have the adenoma phenotype, plus on CT, they have a unilateral macroadenoma, contralateral adrenal is totally normal. That patient, you can't skip ABS. If you want to do ABS, do ABS. But those are the cases where you could potentially skip ABS. Unfortunately, that's not a huge chunk of our patients. But it would be a common email question I'd get, 22-year-old woman, with unilateral macroadenoma, do I really need to do ABS? My answer is no.
But in that case, if you saw the thinking, you would consider.
So the comment is, if the patients, that young patient, that 33-year-old patient CT looked like the case we presented today, macroadenoma on the right, but thickened on the left, I do ABS for sure. Yeah. The point about age is that the development of adrenal nodularity, this is proved with autopsy studies, is in part dependent on age. As we get older, we get nodules lots of places, including our adrenal glands. And less than age 35, it's a very unusual amount of adrenal mass. We're there.
You told us about the ABS that you didn't like the result, from somebody who said it to you. So based on what you found nationwide, is ABS available in every city? Do you trust them?
So the question is in the U.S., is ABS available in every city? The answer is no, especially small cities. Big cities, it may be available, but it may not be reliable. In that article, I'll just tell you a couple of what we said was, first of all, you need a person. You need an interventional radiologist that's not as concerned about making money, that is keen to help patients with PA, who understands the endocrinology behind it, who doesn't give up after trying 15 minutes to get into the right adrenal vein, who, if they don't get into the right adrenal vein, it destroys their day, it destroys their week. They feel terrible. Those are unique people.
Where are they? Where are they?
Where are they? Well, I would argue, most major centers probably have somebody like that. I don't think it takes the most talented catheter pusher to do this. Now, there are some tricks, no doubt about it. And so interventional radiologists will come to Mayo Clinic for a week and learn those tricks, for example. They go back home, and the more they do it, the better they get. The other, the secret at Mayo Clinic is when Jim Andrews is in town, we can do AVS. If he's on vacation, we don't do AVS. We send the patient home. We got lots of radiologists, but we limit it to one radiologist despite our big center. So those are some of the keys, and I kind of know where the areas of expertise are in the U.S. because I've done a map of the U.S. I plotted out where all our patients come from for adrenal vein sampling. There are some places that we just don't get any patients, and those are the areas of expertise. Most are on the East Coast. Yes?
So it's so difficult to get this AVS, and even in higher centers, and whenever there is an element of the doubt, and we're not actually curing the patient. Whenever it's very uncontrolled, always better to add spironolactone and get a good response, continue the patient happy with BP well controlled.
So the question is, if you're uncertain about the AVS results or you don't trust them, is it better to give an MR antagonist? The answer is sure, yes, absolutely. Or you send your patient to a place that can do AVS. So let's see what else I have in this slide deck. So to summarize this case, well-documented primary aldo, adrenal CT showed a 3.7 centimeter nodule on the right, some mild thickening on the left, AVS localized to the left, left adrenalectomy, 6 mil cortical adenoma, post-op PA is cured, hypertension is dramatically improved. Remember, he was not controlled on 4 drugs. Now he's controlled on low-dose 1 drug. So some key points. Endocrinologists try to make PA complicated, but it is not. Check the aldo-renin ratio on blood pressure meds. If renin's suppressed, you're golden. If renin's not suppressed, fine. Stop, replace the potential offending drugs, and reassess a couple weeks later. Perform AVS at a center with established protocol and high volume experience. Having a single, dedicated, engaged interventional radiologist is key. It's important to get this right. A car ride or plane ride is worth it. Laparoscopic adrenalectomy is a one-night hospitalization. Patients are back to work in 7 days. Key to success is a high-volume adrenal surgeon who's dedicated, engaged, understands PA. In the U.S., we call them endocrine surgeons. We actually have specific training in endocrine surgery. It's a 1-year program. Check the aldo the day after surgery, just as you would check a serum cortisol the day after pituitary surgery for Cushing's. Adrenal CT is a poor test to distinguish between a unilateral aldosterone-producing adenoma and bilateral idiopathic hyperplasia. Here's the patient with well-documented PA. On every cut, that left adrenal appeared normal. There's a nodule on the right. Where's the aldosterone coming from? The left. Another patient, some thickening here in the right adrenal, a really nice nodule on the left. Where's all the aldosterone coming from? That little thickening in the right adrenal. Don't trust CT. The surgical management is sought. Having access to a center with expertise in adrenal vein sampling is key. Expert adrenal surgeon is key. Let's just go over a couple email consults on PA. Spironolactone and the aldosterone-renin ratio. I was hoping to get your input on a patient. I have a patient with significant hypertension, resistant hypokalemia, who I feel strongly has primary aldo. However, the case is complicated by inability to wean off spironolactone due to concern for recurrence of hypokalemia. In light of the fact her presenting episode was cardiac arrest, felt to be due to her significant hypokalemia at the time. I have questions specifically regarding the elderine ratio on spironolactone and ABS on spironolactone. I know you're quite busy, but would you have time to do a case? Okay. If the plasmine activity is suppressed on the current dose of spironolactone, you can do any test you want, including adrenal-based sampling. Spironolactone does not interfere with the laboratory measurement of aldosterone, but rather, if the dose is high enough, it can block aldo-action, allow renin to rise, and that's when spironolactone's a problem. Because if renin rises, how do you know if the patient has PA? So renin has to be suppressed. So I advise this person, simply measure renin right now. If it's suppressed, you're good to go. A subtle but important point that I've made in my up-to-date section on primary aldo. So this continues. Thank you. Sometimes these emails go back and forth 10 times. Thank you for your prompt reply. I had read your up-to-date section and other literature, and I did obtain the aldo reading when I saw the patient a couple weeks ago. Aldo was 41.1, renin was 0.6. This is on lisinopril, 40 a day, spironolactone 50 BID. I consider this a very positive screen. 53-year-old female, she had a CT before I saw her, 1.3 centimeter mass in the left, some thickening in that adrenal as well. Given that her clinical scenario, initial labs, I plan to skip confirmatory testing, move straight to ABS. Do you consider PRA to be sufficiently suppressed to proceed with ABS? And he makes another point. This is actually a point I was successful at getting into the new PA guidelines. And that is if you have spontaneous hypokalemia, zero renin, high aldo, what's your differential? Hypertension, spontaneous hypokalemia, zero renin, high aldo. Yeah, there's only one thing, right? PA. And the old guidelines said everyone had to have confirmatory testing. It's not what I ever did. That's not what I do now. So the new guideline also has a nice little dashed line around confirmatory testing if your patient has spontaneous hypokalemia. So my answer to this question is, do you consider a PRA to be sufficiently suppressed to proceed? The answer is yes. The patient's on spironolactone. Spironolactone does not interfere with the measurement of aldosterone. It's physiology, guys. We're good at that, right? We understand physiology. If the dose of spironolactone is high enough that it blocks the MO, so aldosterone doesn't work. If you have a patient with PA but aldosterone doesn't work, then they're going to get volume depleted, renin's going to go up. You can't do any tests. But here's a patient with refractory hypokalemia. If the patient's hypokalemic on spironolactone, I guarantee you the renin's going to be low. They're hypokalemic because aldo is working. They're not on enough spironolactone. So this patient probably needs to be on 300, 400 milligrams of spironolactone to completely block the MO. Okay, how are we doing on time? 5 minutes. Okay, a couple more questions. Lisinopril and confirmatory testing. I'm aware of the fact that screening tests can be done if the patient's on lisinopril. Can they remain on lisinopril for confirmatory testing, either 24-hour urine aldo or saline infusion? As long as renin is suppressed, you can do any aldo-related test on any medication. I could say that 10 times. And I tell you, it's a hard thing to drive home. Yeah, because we kind of learn different things in medical school and in our medicine residency. Correct doses for spironolactone. Junior faculty asked a few questions, ABS in December, appreciate your help. I'd like to ask another question, this time regarding the dose of eplerenone. My patient had an aldo level greater than 500 from each side on ABS with appropriate cortisol proportions, so bilateral hyperplasia. He's 44 on eplerenone, developed gynecomastia after 2 years of spironolactone, and amlodipine 10 with normal BP. But even with 100 milligrams of eplerenone, his case stays in the high 2s on high potassium diet without potassium supplement, and he hates taking potassium supplement. That's a very common experience. Patients don't like taking K-tabs. With 20 milcoins twice a day, his K's run around 3.2. I was just wondering, can I increase his dose of eplerenone further? I couldn't find any data for it. Is there anything else that can be done to help his hypokalemia? The correct dose of eplerenone is whatever dose it takes to get a mid-normal serum potassium without beta potassium subs. In the phase 3 trials, we went up to 400 milligrams of eplerenone a day. There's no toxicity related to eplerenone. Eplerenone is expensive, so you can spare the expense some by adding low-dose spironolactone. Like you could add 12.5 of spironolactone a day and also give eplerenone. Amiloride is a third, but not a good option. I prefer spironolactone and or eplerenone. And let's see, how much time do we have? This one. We'll try to do this one. 47-year-old woman, hypertensive, 10 to 15 years, archtychopulemia. CT shows 2 centimeter adenoma left adrenal, right adrenal normal. ABS has been done twice, not able to get into the right adrenal vein. Tried to switch the patient's spironolactone and eplerenone, so not tolerated it due to increased creatinine and arthralgias. And here are the sampling levels. This is actually an email from somebody in Sweden, so it's in SI units, but I put it in convention units in blue here. So Aldo from the right adrenal vein is 54, from the left adrenal vein 23,000. Cortisol from what was thought to be the right adrenal vein is 54, left adrenal vein 429. Aldo in the IVC is massive, 247. That's a whopper, that's huge. Cortisol is 42. So you can see the gradient of cortisol from what they thought was the right adrenal vein, 54 to 42, that's not five-fold, so they didn't get in on the right. But look at how high the Aldo is on the left, and look how high the Aldo is on the IVC. So this is what I said. Off the surgery she goes. Rationale, left adrenal vein Aldo of 23,000 is unheard of in bilateral hyperplasia. An IVC Aldo over 100 is always an aldosterone producing adenoma. An IVC Aldo greater than 100 requires a big factory. It's always an adrenal macroadenoma, which they have. Could she have a micro APA on the right? Sure, anything's possible. But if present, it's a minor contributor to the big picture. One word of caution. The increase in creatinine with spironolactone is not any nephrotoxicity of spironolactone. It is MR blockade of spironolactone unmasking her underlying CKD. The same thing will happen post-op. Never a reason to not treat. If you don't treat, you'll have end-stage renal disease in a couple of years. But pre-op, the patient should be made aware she has underlying CKD. So these patients are all hyperfiltrating. The creatinine looks better than it is. So if you have a patient with PA with creatinine 1.6, the real creatinine is about 2 or 2.1. And I think with that, we're done. Thanks very much.